Hey, what's up guys? My name's David Hinden. I am a trauma surgeon, and usually I make videos about innovation and history in medicine and creativity. But today, I'm gonna be reacting to some new videos by the hilarious Dr. Glaucomflecken. So let's go.
And we are all done. Nurse, let's get the next patient ready. Okay, we'll need about 20 minutes for turnover.
Fair.
What? Yes, 20 minutes. Are you sure? Yes. We'll call you when we're ready.
I'm just gonna pause here and say that a 20-minute room turnover really isn't that bad. So part of the joke is that he's getting all bent out of shape about room turnover that most surgeons would be pretty happy with.
Thus began the longest 20 minutes of my life. What would I do? Who would I operate on? How could this be happening to me, the most important person in the hospital? I passed the time by dictating notes and yelling at residents for no reason in particular. But even after all that, only 4 minutes had gone by. I tried to motivate the OR staff to work faster by staring at them with my arms crossed. I even let out a heavy sigh to express my displeasure.
I'm just going to say that OR staff that turn over rooms work so hard. It is a ton of work to turn over a room, especially after a big case, because you are having to clean up often blood and other things off the floor. You're having to mop, you're having to sort of sterilize or sanitize equipment, have to restore the room to its original settings. And the more technology that was involved in the case, the more equipment has to be cleaned and prepped and sort of reset for the next case. So it's actually a lot more than just putting new stuff in the room.
You want to grab a mop? But nothing worked. I wandered the halls watching other surgeons operate, telling people what to do, asking for instruments they didn't really need, giving condescending glances to anesthesia. Living my dream.
So wrong.
Peering through the window, I frowned disapprovingly at my own OR staff. It only seemed to make things worse. Finally, I collapsed onto the sofa in the surgeon lounge, unable to muster the energy to eat the free snacks. I was joined by other surgeons, each of them despondent, the scourge of turnover time sucking out their soul like a dementor's kiss.
I'm going to point this out. Actual things that we do during turnover times, some of them are in here. We typically dictate the case that we've just done, so that way when it's fresh in our mind, we're capturing it in a document. We usually go to speak to any family or loved ones that have come with the patient to let them know how the case went. Sometimes, depending how long the turnover is, we'll go speak with the patient as well. Although there's a period of time right after surgery where patients will have amnesia because they still have the anesthesia medicine on board. So typically when I'm helping to roll a patient out of the room, if they ask me how things went, I know that anything that I say in that conversation will typically be forgotten within a couple minutes. So there's a buffer time where we usually wait before we go back to talk to the patient, knowing that the conversation will be forgotten minutes later. But let's keep watching.
So many questions running through my mind. Would I ever operate again? Should I help with turnover? Am I the drama?
I'm going to say it's a double-edged sword offering to help with turnover because it has to come from the right place. If you are offering to help out and it's clear that you are being a team player and want to be useful to the staff, that's appreciated. If you are being rude and pushy and offering to help out in a way that's passive-aggressive and sort of makes people feel even more stressed, don't be that guy or gal.
Thank you, everybody, for coming. 4th of July is this weekend, and all of you are on call. I thought this would be a good opportunity to get to know each other. So I'll hand it over to your team leader, Emergency Medicine.
Just going to say real quick, covering shifts at the hospital on holidays is, no one wants to do it. It's not the most fun thing in the world, but there is a special kind of camaraderie that you develop. I remember a 4th of July when I was in training that we all went up onto the helicopter pad during some downtime and had a little portable barbecue grill and grilled some burgers. And we maybe spent 10 minutes up there and then we got back to work, but it was a special memory that I'm gonna have forever. So covering holidays is not always as terrible as it seems.
Yeah, so 4th of July weekend is the time of year when the general public decides to dabble in explosives.
Sure.
It's just another weekend for us in the emergency department, but I realize this might be a little different for all of you, so I'll go ahead and introduce the team. First, we got Ortho. What up, call bros? There's generally a lot of alcohol consumption this weekend, followed by people jumping off of things and fracturing their arms and legs.
It's true. And unfortunately, in places that see a lot of trauma, like the place that I trained, there are explosives injuries. There are the typical blunt trauma of people being inebriated and falling off things. But unfortunately, on holidays like this, there is also violence. And that is part of the patient population that can unfortunately generate volume at the hospital.
I'm ready to go, Bike Bro. I won't let you down. Yeah. Next, we have trauma surgery. He was the only one who specifically asked to be on call this weekend. Bring it. Okay. Then there's radiology.
It's true. Trauma surgeons unfortunately see a even higher volume of penetrating trauma, blunt trauma, and just trauma in general after weekends that are holiday weekends. So we see a higher volume on July 4th. We see a higher volume after Super Bowl, especially if you're in the home city. We see a higher volume after New Year's.
Then there's radiology. He's going to use a lot of words to tell us whether or not a patient's hand has exploded. And please provide adequate clinical history. I don't want to have it exploded. There.
So there's a real reason why they're talking about this. Radiologists often ask the ordering physician, when you order a CAT scan or an X-ray or an MRI, they will often ask you to clinically correlate or to give them some clinical history about the patient that you're ordering the imaging for. And this is really helpful for the radiologist to not only know what they're looking for and start to hone their suspicions, but it's also helpful for the radiologist to understand if something different that they're seeing in the imaging that's unusual has real clinical significance or if it's just a insignificant variation that the patient has.
There's your clinical history. All right. Face, hands, just exploded. That'll do. Thank you.
All right, let's watch another.
United Prior Authorizations. How can I help you today? Hi, yeah, I'm trying to get a brain MRI approved for a patient. Oh, I'm sorry, we're not going to be able to do that. What? I haven't even told you about the patient yet. Well, we always say that at the beginning of every prior authorization, hoping that you'll give up immediately.
Okay, this is funny because it is literally true. This isn't even a joke. This is right out of the playbook, at least from everything that you can see in medicine, right out of the playbook of insurance companies. Half the time they deny something outright because they know that if you don't fight back, it's already denied and it's one less thing that they have to pay for.
So, you give up? No. Okay, what did you say you wanted? Some kind of picture? An MRI of the brain. I have a patient who might have a tumor. Oh, hold on. Have you thought about an X-ray first? Excuse me? Yeah, according to the United Healthcare How to Practice Medicine pamphlet, an X-ray is cheaper and therefore better.
There's a lot to unpack right there. First of all, insurance companies will often require patients to go through a cheaper therapy first and to fail a cheaper therapy before they will pay for a more expensive therapy. So here they're using the example of imaging, making them try the cheaper imaging, the X-ray rather than an MRI, which is ridiculous because they show completely different things. But this also happens with therapies. So patients with inflammatory bowel disease who are prescribed a very effective medication considered a biologic may first be required by insurance to fail on medications that don't work as well and have worse side effects. They will not be approved and insurance won't pay for these really expensive medications until the patients have gone through this other therapy. Often this is situations where patients have already failed this therapy before in the past, possibly even with different insurance providers, but still have to go through this all over again.
An X-ray is for bones. Huh? It's not what you think.
Poor ortho bro.
There are no bones in the brain. We need an MRI. Have you explored other diagnostic modalities like palpation? You can't palpate a brain tumor. It's surrounded by a skull.
True.
Oh, I thought you said there were no bones in the brain. We're not going to get very far if you're not honest with me. Listen, the patient has headaches and hemiparesis. Well, why didn't you say so? Okay, thank you. Now we're getting some. We'll need 6 weeks of PT before we can approve an MRI. What? You never know. Maybe some leg lifts will improve the paralysis. Okay, I'm going to need your name and your supervisor's phone number. Okay. I'll approve your patient's MRI. Great. So I can call the hospital and get it scheduled? Oh, no. You can't do it at the hospital. Why not? Hospital charges us way too much. Now, there's a facility about 150 miles south of you. Patient needs to go there. Are you serious?
This also is not even funny because it's true. Stuff like this literally happens all the time.
Oh yeah, there's a guy down there, bought himself an MRI. It's in the back of a Texaco. Just knock on the door, ask for Mike. But the hospital's a block away. Listen, do you want your patient to get an MRI or not? Yeah. Then you send them to see Texaco Mike. And they'll be able to get an MRI? Yeah. Kinda. Wait, what does that mean? Well, the patient's plan only approves a walk-by. What is that? The patient just walks briskly past the MRI machine, and Texaco Mike just gets whatever images he can.
Oh my gosh.
Also, your patient hasn't met their deductible, so this will be out of pocket.
This is so wrong, but so true in so many ways.
Good morning, doctor. Pathology? You're an hour early. I know, I was just so excited for our meeting. You're excited? Yes. Who wouldn't be excited to see you? Have you met the doctors who work in this hospital? Well, I did meet the ophthalmologist once.
Pathologists are typically really nice. Like if there's a stereotype about pathology, their personality stereotype is that they're nice. And that's a stereotype that I don't think hurts anybody.
He was extremely lost. Well, come on in, sit down. How's your day going? It's going great. Are you enjoying your job? I'm a pathologist. It's the best job in medicine. Very good. Any interpersonal conflicts? No, of course not. Okay. Have you lost your temper with anybody lately? Only the clock for not giving me more time to practice pathology. Do you welcome med students and residents into the lab? Oh, we love trainees. Are you getting enough sleep?
I will say that being invited into a pathologist's lab or stepping into a pathologist's lab is really, really special for everybody involved because the pathologists get to really get a taste of what's going on clinically and like what you are thinking at the bedside. And if it's you going to the pathologist lab to look at a tumor under the microscope, you can really help give them some context for where the tumor was or how close those margins were in the operative field. And at the same time, for us, it's really helpful to talk to pathologists, whether, again, it's looking at a tumor and sort of seeing what they're seeing, or unfortunately, when our patients pass away, sometimes it can be really helpful to go to the pathology department and look at the autopsy with the pathologist if there's any question as to what was going on clinically with the patient.
8 hours every night. Are you happy with your work-life balance? Couldn't be more balanced. Is there anything bothering you whatsoever? No. Pathology, why are you here? Just thought it'd be fun to chat. Your mental health is perfect. You don't need to see me. Well, I already made a bunch of appointments. Oh, that's not a problem. I'll give your slot to the neurologist. He could use the extra time. Oh, okay. You hear that, Tabitha? Our mental health is perfect.
I hope Tabitha is a microscope or a slide. Let's just see.
What was that? Oh, I was just talking to Tabitha.
Let's see.
Tabitha is your microscope.
Oh,
Yeah.
there we go.
We've been together since residency. And you and Tabitha have conversations. Oh yeah, we talk all the time. Pathology, do you have coworkers? Of course, there's Tom and Josephine. Oh, good. How long have you been working with Tom and Josephine? Well, we just bought them last year.
Oh, no.
You bought them? Yeah. Pathology, are Tom and Josephine, by chance, pieces of lab equipment?
Oh.
Yeah, Tom is a hemocytometer and Josephine is an electrical microtome. Don't you want to interact with people during the day?
A hemocytometer is a piece of equipment that lets you sort blood cells and better see characteristics of individual cells. And a microtome, even though you will probably never care about this and never need to know it again, is a piece of equipment that slices tissue incredibly thin, like thinner than a slice of paper, so that they can put it on a glass slide and look at it under a microscope. Useless information. You're welcome.
Not really. Why? Because we're social creatures. We need companionship. I have a companion. Tabitha is a microscope. Tabitha is an Omax LED compound microscope. Show some respect. Pathology, she is not human. Tabitha is reliable. She listens. I can trust her. Do you know any humans like that? Come on, Tabby. Let's let the doctor think on that.
That was great. If you want to see more reaction videos, click here on the screen. And if you're not yet subscribed, click right here. I'll see you soon.